will be joining too, Prasad. I think probably
Okay.
better to use English rather than Telugu. I think it's going to be more. Some of them will be non-Telugu speaking, so I think it's nice to let's go with English rather than Telugu.
Okay. Sure.
I think more people are going to be on the live stream rather than joining
Yes.
the session.
Yeah. Dr. Gangasani Garu and Dr. GARIMELLA GARU. You can able to see the PowerPoint, sir?
Yeah.
Okay.
Thank you.
No, Josna Garu and Raghuveer.
Yeah,
Yeah.
I'm here.
Yeah, I think we will wait a couple of minutes and then we will introduce Dr. Gangasani Garu and Dr. Prasad GARIMELLA GARU. But before you introduce both doctors, just introduce our GATES team. So then I will take a couple of minutes. What GATES basically, activities we are conducting. From there, then you can introduce Dr. Gangasani Garu and Dr. GARIMELLA GARU. So that still people are joining with us. So is that okay, Dr. GARIMELLA Garu and Dr. Gangasani Garu? Can we wait a couple of minutes?
Yeah.
Okay. And please, everybody just stay on mute.
Prasad, you want to go first so that if you have to go to the hospital, I think you have to finish the rounds. I think let Dr. GARIMELLA go first. I think he's in the hospital. So he's the one hardworking doctor, work last night, working the rounds and still giving us the time. Thank you, Prasad, for doing it. But I think let Prasad go first so that at least he can work and then come home and sleep so that he can go back to work tonight.
Sure, Dr. Garu.
Sure. Thank you.
I think Josna Garu, I think let's we start. Raghuveer, are you there?
Yes, I am here. Good morning. Good afternoon. All.
Yeah, any one of them, can introduce Josna or you or Raghuveer. Raghuveer, are you now comfortable? I know you.
Yes, I'm comfortable.
Okay.
Yeah.
Okay.
Good afternoon, all. Good afternoon, Dr. Srini Garu, Dr. Prasad Garu. Few words about our doctors. Dr. Srini Garu, he's a founding partner of cardiovascular group in Metro Atlanta and practiced cardiology for past 20 years. He graduated from Kurnool Medical College, which is part of University of Health Sciences, with multiple gold medals. He did his residency in cardiology fellowship from William Beaumont Hospital, Oakland University, and started his practice in Atlanta during the year 2000. He's also board certified in cardiovascular medicine, echocardiography, nuclear cardiology, health failure, and transplantation. Dr. Srinikaru served as chairman of American Association of Indian Physicians, AAPI, convention during 2019 and also 2021. He was also chairman of API Global Health Summit held in Hyderabad during 2019-2020. He served as president and chair of board of trustees of Georgia Association of Physicians of Indian origin. Also, he was elected as AAPI Board of Trustees and served as Vice Chair of BOT. He is founder, director of GAPI, Georgia Association of Physicians of Indian volunteer clinic, serving uninsured Georgians since 2010. He was appointed by Governor of Georgia to Georgia Composite Medical Board. He's a co-founder and chairman of board of directors of Global Doctors. It's a telehealth company which was instrumental in helping the patients during pandemic. He won multiple awards, including Hope Clinic's Compassionate Doctor, Best Doctor by his peers. He was also recognized his charitable services by multiple associations, including ATA, TTA, GATA, and our GATES. He has unique distinction of a patient donating 100K of his on his behalf to help develop doctors like him. Thank you, Dr. Garu, for having here today.
Thank you, Raghuveer,
Yeah.
for that. That's a long introduction. I think
Actually,
I wanted a brief introduction, but thank you.
I want to add something here. I'm like, how much did you achieve it? And we are so honored. We are so lucky that, we got your time today. Dr. Garu, it's really amazing to see, that we know you and you're always there for us.
Thank you. Thank you, Justin.
Yeah, thank you, Justin. Our Dr. Prasad Garimella's information. He is also graduate from Kurnool Medical College. He is board certified in internal medicine, pulmonary medicine, critical care medicine, and sleep medicine. He's working at Gwinnett Pulmonology Group since March 2004. He's a board member of Gwinnett County Hospital Authority. He's the director of medical services Northside Gwinnett and Duluth. He's associate professor of clinical medicine, Philadelphia College of Osteopathic Medicine, and Georgia campus. Thank you, Dr. Prasad Garu.
Thank you, Raghuveer.
Yeah, thank you, Raghu. And thank you, Josna Garu. Thank you, Dr. Gangasani Garu, and thank you, GARIMELLA Garu. I will just take a couple of minutes before you guys are taking the questions. So right now I'm the current president 2023, and also we have the team. This is the EC. Sandeep Reddy Gunla is the vice president, and also we have a secretary Naveen Battani, and Srini Parsa is the chairman. Treasurer we have Ramana Gandra, and also cultural secretary Kirti Dargaud Chakila, and also Ganesh Kasam, media secretary, and we have event secretary Chalapati Venamaneni, and also past president Sunil Goturu and Prabhakar Madhupati is the past chairman. And we have a board of directors, Ramachari Nakirti, and also Josna Palakurti, and Ramakrishna Gandra, and Geeta Naranagari. This is the current 2023, the board. And also what do the GATES do? Basically, as you all aware that we do a lot of, virtual sessions like health, and also that right now, we started with the health session. And last week, couple of weeks ago, we have conducted the Martin Luther King, that's a part of a youth enrichment program. And also we do organic farming, and also step challenge, sports and nutrition, and also COVID. A lot of, last year also Dr. GARIMELLA GARU and Dr. Gangasani Garu conducted the COVID sessions. And also we do investment seminar, blood drive, life insurance, yoga, adopted a road. This year, actually, we adopted a road from Ronald Reagan to Old Atlanta Road. So the youth students, they can participate in getting the community service hours. And also we do the food drives, serving the breakfast to police department. And also we have some new initiatives like Women's Day we are planning to do, and also scholarship to merit students in India. And also we're trying to do painting to elementary schools in India. Book distribution to elementary schools and libraries, sessions and college essay writing, getting admissions in Ivy League colleges, introducing the youth committee. And also kids talent show we have on March 11th in Shiloh Pond Elementary School. And also acknowledging and recognizing American Festival through flyers or any small gatherings. And also youth committee, and also distributing boots to the farmers. As you know that farmers is the one that work so hard, to provide the nutrition to us. So we are trying to, distribute some boots for the safety, so they can work. So they can take care of their health. And also, these are some of the pictures. These are some glimpses what we do the GATES, like the food drive, and also like this is we balance between the cultural events and also the service-oriented projects, and also glimpses. So this is the GATES. What the GATES do means, these are the projects we continue. And please supporting GATES. And also today's YouTube live streaming going on, and also we have a Facebook page. So please keep in touch with GATES. Thank you. Please go ahead, Dr. GARIMELLA GARU, and it's your time.
Hello all, good afternoon. I'm Prasad GARIMELLA. I'm a pulmonologist, critical care doctor, and sleep doctor. I think the session is mainly going to be open. I think fortunately, I'm going to talk about the COVID and give you general instructions or how we can maintain healthy living. Fortunately, things are going well with the COVID, and even though it's coming up and down, there's some issues with China right now. But I think overall, people are very relaxed. There is no panic pandemic like we used to have 2 years ago. We have the situation appears to be under control, mainly because we have the medications. When people have the problem, they can take the oral medications even before they get to the hospital. We have the vaccines to prevent them. We have much better treatment options available. So the situation is good, but it is very important to know, in spite of all these advancements or improvements that we see, there are people who are we still see them in the hospital, ICU, and we are still losing some patients to COVID. So it's very important to know who they are, and that way you can take the best prevention methods and be on the active preventive side. So people who are above the age of 65 are at high risk. People who are in nursing homes are obviously at high risk. It applies more here. Nursing homes here are basically people live there, whereas back home in nursing homes mean hospitals back in India. But anybody who has cardiovascular disease, COPD, which is chronic obstructive pulmonary disease, chronic kidney disease, diabetes, any dementia, obesity is BMI of more than 30. You all should know what your BMI is, and it's very easy to calculate. It's a height and weight relationship, and it gives the body mass index. If it is 25 to 30, then it is considered overweight. Above 30, it is called obesity. So 25, there is also a theory that for Indians and Asians in general, 23 to 28 is considered overweight. So in general, it's better to be below 23 if possible. That brings our, how do you maintain healthy weight discussions because obesity is a risk factor for bad outcomes in COVID, not only COVID and multiple other medical conditions that we see. So it's always an important aspect. So people who have cancer, cystic fibrosis is another lung condition that usually seen in kids, and it's not common in non-whites, fortunately. And immunocompromised people, anybody who has liver disease, pregnancy, transplant, all these people are at high risk for COVID-related morbidity and mortality. That means increased death rates, morbidity, mortality, morbidity meaning they are more sicker when they get that that infection. So that's very, very important, because for every condition that we deal in medicine, we always start with what is the risk of that patient to acquire any problem. So in regards to COVID, we went over these risk factors. Who is more likely to have problems, more likely to be in the hospital, more likely to die. So that's very important to know. If you go to CDC website or even NIH website, these risk factors are easily available. If anybody is at risk, they need to be very careful. You are the caretaker or your parents have one of these things, just give extreme caution, because it's a lot better to prevent the problem than to deal with it afterwards. We all went through, at least one or two of our family members all had, every one of us had, experience with the COVID in the family, and we are dealt with that, right? So prevention is the key. So what do we have for prevention? Obviously, vaccination, and then the social distancing. So it's I cannot emphasize any more how important that prevention is, especially for the people who have those risk factors. If you do not have the problem, but your a loved one that you live with or you are close to have the problem, you need to make sure that you are not the person who is transmitting or giving that infection to the person who could be ending up in the hospital ICU, or hospital or in the ICU. So vaccination, there's a lot of data, so that it will definitely decrease. It does not eliminate. So it's not like you take a vaccine and you eliminate the COVID. So that is kind of we are not at a state where we can say that you got the vaccine and you are not going to get COVID. So the main concept I want, the take home message is, like in medicine we have, is called infection versus disease. Infection is it's in your body. The disease is that you have organ damage or some problem with that infection. So those are two different things. So we can probably decrease the risk of the disease or what it causes to your body by taking the vaccine. The infection is like you are still prone to it, even though it reduces the infection risk. It's more important to decrease the disease effect of that disease on your body. That's the main thing: vaccination and social distancing, and doing all our things that we all know. Even a fifth grader knows nowadays about all these things. The main point is, it's not just the knowledge of what we know, it is the habit of putting it into action that makes the big difference, like many things in life. So that's in general about the who is at risk and how you can prevent the risk. Say next step is, if say for example after a flight trip, or you have somebody have the COVID, obviously testing is important, and making sure that you distance yourself, or so that others in the family don't get that. That's important. Number two is, like, if talking to the primary care doctor or any physician. Sorry about that. So that if you are a candidate for getting this treatment with oral medicine, which is a Paxlovid, which is a Pfizer product, it's a combination of 2 pills taken for about 5 days. Using those things will be a good treatment option. If your physician feels like you are a candidate for that, they can give a prescription for that. That will also decrease your risk of going from a mild infection to a severe disease. That's next step along the way. And then if it is progressing further, obviously coming to the emergency room, getting all the testing needed, including the oxygen testing, the chest X-ray, the blood test, and once that provider, the physician is going to evaluate, see what kind of a treatment you need, whether it is going to be in the as outpatient setting, or need to be admitted to the hospital, or need to be admitted to the ICU. All that will be decided by the doctors. So, but that's how the treatment goes on, and we have fortunately multiple treatment options available to take care of these patients, but it is not 100% that we can save everybody. We are still losing people to COVID. So that's important to know. So this is about COVID, and I'm very passionate about medicine. I just want to give my public service announcement if the time permits. Is that okay, Janardhanji? Jyotsnagar?
Yeah. Yes, sir. Yes, Dr. Garu.
Prasad, can you just say one thing about the strains, new strains, old strains? What is if you can take like a 1 minute comment about, a lot of people have questions about the strains most of the time.
Yeah, please try to be mute all the viewers so that we can able to hear the doctor's message. Thank you.
Right. So like any virus, thank you, Srinu. I'll address that. So all the viruses, not just the COVID virus. COVID virus belongs to the family of viruses called coronavirus. There are 7 other coronaviruses that are present even before the COVID. So they constantly mutate. That means that they change their genetic structure by a small amount. So there is a shift and drift kind of a terminology that we use. So they adapt constantly. So because of their genetic structure, they can kind of overcome the host or the human's ability to fight the immunity. So because of those reasons, you are going to have new strains that are going to come on. Obviously, we all know about the different strains that we had. The Delta was the deadly in India, and also here has a higher mortality, whereas the Omicron was not that serious. Right now, the data from China is kind of even for WHO, it is very hard. So there are some of these some information that is coming in. Most of it is coming from non-medical research base, and more from the press. So until and unless we see that coming into United States or outside the China, I wouldn't be too surprised. I think there is a big difference between the Chinese population and elsewhere. One of them is the different kind of vaccines that we got. So they have a less amount of effective vaccination in China, and people believe that that is one of the major reasons why they have more of a problem nowadays. So unfortunately, because this is all mixed up with the politics and whether people like China or not, so a lot of the information comes in that there are patients being, dying left and right. But unfortunately, we always depend on the evidence. And the evidence from China is not easy to come, and that's a big struggle. I don't want to alarm people about any strains, but on the other hand, I think I'm going to give the confidence to people that, okay, be on the lookout for, with regular things. But as the numbers go up, or if we get the new data that the Chinese strain or some other strain is getting worse, don't be too like cowboys and say that nothing is going to happen or things like that. So follow the advice that is given through the NIH and the medical authorities. That's what my take on it is. As far as my public service announcement is concerned, I see in a lot of our Desi circles, there is a lot of this, casualness as far as health is concerned. I am not saying it just to make fun of people, but what happens is usually we are reacting to the problem than being proactive. What do I mean by that? Is that people are not taking care of their health regularly, and that's why whether we take about the heart disease or whether we take about the diabetes or any other things, we are at high risk. We are at risk with a lower at a lesser age. And we see this all the time, and many conditions we are at high risk, heart attacks and other things. So I think taking the your health into your hands and doing the right things in the form of 4 simple principles. Basically, one is a good sleep. The second one is a good food. A balanced diet. And number 3 is that day-to-day exercise. And number 4 is simple thing is to make sure that you are not stressed out. I mean, obviously coming over across the world, it becomes so hard for us. I mean, we cannot avoid the stress, but it's our adapting to that stress. Is the stress is always going to be there. The bad stress that gets to the body is what you need to avoid. And those 4 simple principles, if everybody follows that, I think we are very, very successful community in the United States. But I think we do have these maladaptive behaviors in the form of the habits. So we see that that's one thing that I wanted to focus, and we call that as self, sleep, exercise, living in present, and food. So if you take care of yourself in those terms, make sure that you get 7 hours of sleep and eat healthy and living in the present. It kind of comes from our spiritual literature also, that do your best effort and don't focus on the result, and do your best on a day-to-day basis. And then the last part is that exercise part of it. So focus on those 4 aspects of it. So I work with Seva International. So we have this program called a self program. So we're trying to encourage people to come for these exercise events, and like running or group walking over the weekends, and encouraging each other to stay as healthy as possible. So I encourage people to consider that kind of an attitude towards the health. Number 2, I wanted to tell is taking this opportunity, because we only talk about medicine, but more important is prevention, and then the advice from the doctors is also important. So that's why the second aspect of it I see is like by the time kids are coming to 15 or 15 years of age, there's a lot of calls about, my kid wants to become get into medicine. All that stuff, it is very, very common. Everybody wants to, I mean, there is a interest in getting into medicine. I encourage it. It is a very, very noble profession. We thank our parents and teachers to kind of get us into this position to be of help to people and make our life meaningful. So one of the most important things that I see is like there is a lot of emphasis on drive to become a doctor. But I also think I wanted to tell people is like we are losing a sense of caring, because for medicine, the most important thing is not the knowledge, but your ability to care. Recently I read something about this Hawaiian culture, and in their culture they have this sense of in our culture we call it as dharma, doing the right thing. In Hawaiian culture there is a word called malama. Malama is just basically caring, a pure caring for each other, first your own self and body, and then caring for everybody else, and doing your best. So I want highlight that great principle of malama, and read about it, and encourage your kids to develop that habit of caring for themselves, caring for environment or community, rather than just blindly going after whatever reason they want to get into medicine. Everybody will write nice essays, but practically seeing, I see that there is a compassion deficiency, not just in our community, but in general. There is a community, I mean, a generation difference also. So those are my 2 two PSAs or public service announcement I wanted to communicate to people before I take any questions.
Yeah, Raghuveer and Jasnagar. Yeah, anyone?
That was really wonderful and eye-opener things. Thank you very much. So here, one of our listener is asking a question.
I think Jasnagar.
Yes.
I think Dr. Gangasani Garu, are we going to take the questions, or are you going to be after
Sir,
you?
No, let them.
I can wait. It's up to you. Either way is fine with me.
Let them ask the question. If you have to leave, Prasad, it's okay.
Yeah. Okay.
If whatever the questions for pulmonary,
So one question is like, what kind of test do you recommend to detect lung cancer in early stage? Like, the same question, even I want to emphasize, like suddenly one day we see like, one of the friend diagnosed with lung cancer. And I definitely think like, that won't happen in one night.
Right.
So how get to know that in early stage, or how to prevent? Are there any tests we can go and check?
Absolutely. Lung cancer, if, say, for example, in Gwinnett County, there are, say, some 2,000 cases that are diagnosed every year. 90% of them happen in smokers. So the highest risk is for people who have smoked, and not just 1 or 2 cigarettes or 1 or 2 years. Usually they have smoked for at least 15 years. So again, back to the risk. Who is at risk is people who have smoked. About 10% of the people are like non-smokers, but they have some exposure. Say, for example, their profession or exposure to the chemicals or things like that, or radon exposures, or any other radiation exposure. All of these things are that increases their risk of that. One of the third category that we need to know is like a non-smoker category, why they develop it. Asian women, for some reason, non-smokers, they are at high risk for lung cancer too. But what can you do as a prevention is that if you are living in the United States, there is a government approved research evidence-based protocol we follow that is called low dose CAT scan of the chest. Anybody who has smoked for more than 15 years, about 1 pack per day. So I'm going to repeat that again. Anybody above the age of 50 years and who has smoked for more than 15 years in their lifetime, whether they are currently smoking or smoked before, they should get a low-dose CAT scan of the chest. Not people below the age of 50, but above the age of 50. That is called low-dose CAT scan of the chest to decrease the amount of radiation to the lungs. That low-dose CAT scan of the chest will determine if they have any kind of an early stage of the cancer. And it is paid by the insurance. Your primary doctor can talk to you, or you can, usually primary care doctors are, they all know about this, or any lung doctor can get you that low-dose CAT scan arranged. Once that CAT scan is arranged, it will tell you whether there is any kind of a abnormality or a shadow that need to be worried about or need to be followed.
Thank you very much. Adding to this question, like, one of my family went through this CAT scan test. So I just want to know a little more information. Like, is this CAT scan is to know the is in heart, or does it help in lung cancer?
पूछना पड़ती हूँ दीदी को कितने पैसे चाहिए इसको.
Can someone is unmuted? Can you please make sure that?
Yeah, sure. Thank you. Yeah.
Sorry. So you broke up also in between. So the CAT scan is to.
So my question is like, because I'm like, my family went through some this blockage issue, this thing. So we heard from one of our well-wisher, like, if you go for a CAT scan thing, you will get to know like if there are any blockages in heart or anything like that. So is that the same test is also helpful for this lung scan? I mean, lungs, whatever you have mentioned.
Right. So these are two different ones. The low-dose CAT scan of the chest for lung cancer screening is different than what Dr. Gangasani is probably going to address that. That is called calcium scoring, or that is meant for looking at the blood vessels that supply the heart. So when we do the heart scan, which is called the calcium scoring or calcium CT, it does give us some evidence of some imaging of the lung also, but these are somewhat separate. One is to look at if people have the heart risk, then the calcium score is important. If they are at risk for cancer, like if they smoke, the ones that I talked about, they need the low dose CAT scan of the chest. And this is mainly applicable for India setup. I mean, a United States setup. In India, they may be using, they don't use the low dose CAT scan, but the same evidence can be used for that. Hope I answered your question.
Oh yeah, thank you very much. And another question is like does like chronic cough can be a lung cancer? Like someone has this chronic cough thing, will that lead to a lung cancer?
Not necessarily. It's not as simple as it is. So let me put from one side, from symptoms to the diagnosis, from diagnosis to the symptoms. So make it simpler and easier. Symptoms to the diagnosis is like when people come in with cough, there are 100 different causes for cough, and lung cancer is one of them, but it is the least amount of it. I mean, the lowest on the priority. If somebody is coming with a cough, we think about asthma, we think about nasal drip or sinus disease, we think about reflux heartburn that is causing it. Sometimes the blood pressure medicines causing it. So those are more likely causes for cough rather than lung cancer, unless we also ask what is their risk. If their risk is high, then obviously we do the CAT scan or a chest X-ray to see if there is any nodule. So just because they have cough, thinking about lung cancer is like, unnecessary. That's unnecessary, anxiety-provoking thing. So cough, as a cause for cough, lung cancer is a very low priority. Whereas when people have the lung cancer, I'm going from the diagnosis to the treatment. Yes, almost all the people who have lung cancer, they all have cough, but not everybody who has cough has lung cancer.
So they added to this question, like, the person who has this chronic cough, he has this scar tissue in lungs. So they're asking, like, he's having a chronic cough, that symptom. And he also
time, right?
Okay, so your question is, I mean, just to be, because there was a break and a disturbance. So cough, and there is scarring on the X-ray or imaging. So scarring on the imaging can occur from previous infections, previous inflammations. There's many different types of scarring again, depending on their risk factors and their exposures in the past. So what caused that scarring, whether it is advancing scarring or is it a one-time deal? So a lot of the times if people have severe pneumonia, yes, body heals by scarring. If you have a cut on the skin, it heals by scarring. So if it is a deep enough or severe enough of an infection of the lung, yes, it can cause the scarring. Usually people will get over that, usually do not have much of a symptom from that. But some do have chronic cough secondary to that. And it involves evaluation by the pulmonologist, lung doctor. They will be monitoring their pulmonary function test. They'll be monitoring the imaging of their chest to know the anatomy, the function of it. Will be some chemical structure, chemistries like blood tests. So putting all of them together, their oxygen, the vital signs, the exam, the risk factors, and the symptoms. So that's what we do. Like we combine all this information from different data points and come up with the diagnosis, what is causing that cough, and then come to the treatment aspect of it. So to be able to tell just the cough and scarring alone, what is the reason, what is the treatment? No, I don't think anybody can tell. I encourage that person to get an evaluation if it is bothering them. And I strongly encourage them to get it done earlier than later.
So thank you very much. But I think the listener is adding a couple of questions to that. I think.
Yes. Sorry to interrupt you. I know we mentioned in the flyer only 1 hour, but I know it seems like right now I know it's 12:40 now, and also we have Dr. Gangasani Garu too. Dr. Gangasani Garu, sorry to interrupt you, Dr. GARIMELLA Garu. Do you want to share about the cardio
Yeah, I think I think there was one more question about the parent has a lung cancer. Does any of the kids have a risk of cancer?
Okay.
Question, and we'll close it, and then we'll talk about it. And if we still have time at the end of it, then we can.
Then we can combine the questions. I know Raghu also has some questions, so
Right.
I think you both can address those questions.
So you want me to take that questions, Dr. Garu?
I can take it and then I can leave. Yeah, certainly. So the question is, if one of the parent has lung cancer, does any of the kids are at risk of cancer? Yes. So in general, they are definitely at risk for cancer for a few reasons. It may not be all be genetic. If the parent is smoking, during the time that the parent is smoking, it is possible that the child was exposed to that smoke also. It is called secondhand smoking or passive smoking. If they have that kind of a passive smoking, that can cause them to have the risk. Not everybody who has lung cancer has active smoking. Some passive smokers also get the infection. Is there a genetic test that could be a genetic test? At this time, we do not have a genetic test that can easily identify. There are some biomarkers. The biomarkers are expensive. That is only, we are using it only in people who are already having some chest X-ray abnormality. Just because your parent has a lung cancer history, if you are not a smoker, you don't need to be worried about it. No need to go or search for any kind of a genetic testing. There's no simple genetic testing that can answer or alleviate their anxiety. And then what could we do to the prevention? Absolutely avoid any kind of a smoking or any chemicals that can increase the risk of cancer. And then if they are concerned, if they are above the age of 50, maybe a good idea to get a CAT scan and get that evaluation by the lung doctor. Thank you again.
Thank you very much, Dr.
Thank you so much, sir.
Yeah, thank you, Prasad, for that wonderful presentation, and I think update on the COVID. So we just want to the last few times, I think we did PowerPoint presentations. So this time we just want to have a more discussion with a little bit of a brief introduction. So from my point of view, from a heart disease, especially in South Asians, I just want to divide it into 4 different kind of discussions. One is like, what is the risk of heart disease in South Asians? Number 2, what are the risk factors? Number 3, what can we do, the testing point of view? And the 4th is what we can do from a treatment point of view. I saw some of the questions on that aspect, but I think let me just go over briefly each one of them so that if you have more questions, we can talk about more after that. So let's look at what is the risk of heart disease in South Asians. Let me put in a perspective. South Asians comprise about 23 to 24% of the world population. But if you look at the heart disease in South Asians, we are 60% of the heart disease in the world. So look at this way, we comprise 1/4 of the whole world population, but we have more than 60% of the heart disease in South Asians. This not taking into account people who died. So these are the people presently diagnosed with some kind of a heart disease. So we are anywhere from 3 to 5 times more chance of having a heart disease. When we say heart disease, I'm talking about the blockages in the heart. So I think it's very important to know that genetically, we are more prone to develop the blockages, whether we like it or not. Doesn't matter what we do, where we are born, that you're born in India or you're born in the United States, or I have patients from Guyana, Fiji, anywhere that the generations ago they went to these islands, they're still more prone to develop the blockages. So it's not just the environmental factors, it's genetic factors plus environment factors together. So when our risk is about somewhere between 3 to 5 times more than a Caucasian, the people are Asians, some of the Chinese, Japanese, compared to them, talking about South Asians from India, Pakistan, Bangladesh, Nepal, Bhutan, Sri Lanka, so some extent Afghanistan too. So I think we're all probably same genetic pool. I think that's where I think we cannot change. So what are some of the risk factors we can take care of? Some of them we cannot. So there are risk factors called modifiable risk factors. There are some risk factors we cannot modify called non-modifiable risk factors. So if you take the modifiable risk factors, people, diet, exercise, history of smoking, or cholesterol, diabetes, hypertension. These are all modifiable risk factors. So you may develop the disease, but with risk factor modification or eating right, exercising regularly, and taking the medications, we can control these risk factors to some extent. So there's a thing in diabetes where we call hemoglobin A1C, where we can check every 3 months. So it should be under 7 is good, under 6 is the best. So if you can keep your A1C more close to 6, your chance of developing the risk factor related damage to your blood vessels is going to be a lot lower than somebody is keeping the hemoglobin A1C at 8 or 9 or 10. That means that their blood sugars are not under good control. So you are going to have a more chance of developing the plaque in the heart arteries, brain arteries, kidney arteries, blood vessels in the legs. So we can see a lot of complications from controlled diabetes in the long run. So diabetes, I just want to stress a little bit more on diabetes. Diabetes is in Indians, almost 1/3 of the diabetes, 1/3 of the Indians have diabetes, whether we like it or not. And probably 50% of the people don't even know that they have diabetes because it doesn't cause the symptoms until late. So if you're drinking a lot of water, or if you go to the bathroom too many times, I think if you're gaining weight or if you're hungry all the time, I think definitely need to have your blood sugars checked so that at least you know what the problem is, you can take care of it. And I think especially South Indians, I think South India is like a diabetic capital. I think Hyderabad, Chennai. So those are like a diabetic capitals of the world. So when I was in India last month, it seemed like everybody, I'm taking this diamond, I'm taking the metformin, I'm taking the glyperide. There are so many people are on the medication, but probably 50% of the people still don't know that they have the disease, especially in villages. So the culture has changed, and with the industrialization, with the IT growth, I think our habits have changed. If you look at when we were younger, we used to go to school walking and we used to play outside. Now, none of them, we're not doing that. You just get in the car, go wherever, point A to point B, and then come back and go into the house and go in the AC, and then you don't do exercise. So at least 30 minutes of exercise every day is a must. I think we need to be selfish about ourselves. We need to spend 30 minutes of time for ourselves. If you don't spend 30 minutes for yourself, you cannot help anybody else. So I think that's very important that you need to take care of our body. Nobody's going to take care of our body except us. Not your spouse, not your children, not your parents, nobody. So we need to take care of our body ourselves. So I think we need to be selfish about giving 30 minutes of time for ourselves. So hypertension, the same thing. Cholesterol and hypertension are silent killers. So you don't know whether you have diabetes or not, you don't know hypertension or not, cholesterol or not. So I think like Prasad was talking about, somehow Indian philosophy has been more reactive philosophy, not a proactive philosophy. So I understand when we were younger, when I was growing up in a small taluk in Kolhapur in Mahbubnagar district, so we used to have 2 doctors in whole, like in a Kolhapur at the time when I was growing. So you cannot everybody go to those 2 doctors and take care of it. So we used to go only when you are sick, when you have a fever or when you have something else. But now you have plenty of doctors. I think we need to go get the physicals done, get the cholesterol check your blood sugars, blood pressure, and all those kind of things. I think when you go, you can find out the problem a lot sooner and take care of the problem a lot sooner. Unfortunately, age is one of those non-modifiable risk factors. As we get older, we're going to get the plaque. If there is a genetic predisposition, you're going to get it early. If you don't have a genetic predisposition, you can get little later. So, ultimately, we're all going to die one day. But until then, the goal is to have a good quality of life with as less disease as possible. I think we need to eat that. The diet is one of the most important things. And I think I was talking to one of the nutritionists and dietitians, Shobha Swami, this morning. I think there is so much change happening in medicine. There's a plant-based diet. The lifestyle medicine is kind of changing the whole thing. I think Prasad talked too briefly about it. I think the diet is one of the key factors, along with exercise, to prevent the disease. And even if there is a disease, slow down the progression of the disease. Both are important to take care of so that we can modify our inside what we don't know, but the plaque formation will slow down significantly by changing the diet habits. I think the plant-based diet is good, organic foods are good, but I think ultimately you need to do it in moderation. Whatever you want to do it, but do it in moderation. Don't eat too many sweets, ice creams, depending on what your underlying problem is. I think you need to take care of that. So coming to testing. So by doing some preventative work like the blood work every year, get some blood work done on a regular basis so that you know if there is a cholesterol. Okay, I think the resound, is it better now?
Yeah, it's better, Dr. Garu.
So from a testing point of view, by going to the doctor on a regular basis, get your blood work done so that you know that if you have diabetes and the cholesterol problem or not, and you check the blood pressure regularly once a year, at least once a year, if not more, so that you know if there is a problem with the blood pressure. But from a cardiac testing point of view, after 40, 45, I think it's a good idea to get some testing done with a regular treadmill stress testing, which will show if there is any plaque of more than 70%. So there is a thing called calcium score. I think Prasad was talking briefly about the calcium score. Calcium score is a great test for $100, which is in like a night. Most of the places $99. You can see if there is any plaque building up in your heart. When normally plaque forms as a soft plaque. So when the soft plaque forms, you don't know, you can't see anything. There are no really good testing to see the soft plaque right now. But as the soft plaque becomes, with the time, in 2, 3 to 5 years, you form little calcifications in those plaques, which easily identifiable by using the CT scan. So that's what the calcium score is. It's not real calcium, what's in your body. So it's the calcium. We have plenty of calcium in our body. Bones are full of calcium. So it's nothing to do with the calcium. But whenever there is a soft plaque, majority of the people, this plaque goes into the plaque so that we can see that identifiable kind of a thing on the CT scan, which is easy to identify. So that's what we are looking at, is the calcium score. Is a one shot of the CT. I know, I think Prasad was talking about the lung cancer too. I found a lot of lung cancers by doing these CT scans, because we do check the lungs along with the heart, even though the heart is in the middle, but unfortunately both the lungs are on the both side of the heart, holding on to the heart. So they're really keeping the heart in the shape in the middle, like what Prasad says. So I think, but both are next to each other. So when you do the CT scan, definitely you're going to see if there is a big enough lesions, you're going to see the nodules, a lot of nodules. But I think the two different tests, I think two different things, but calcium score also shows if there is any lung kind of pathology. We can also identify the aortic aneurysms, if there is a hiatal hernia. So there are a lot of other things we see, but mainly we do it for the calcium score is to identify any plaque. Plaque should be 0. 0 is the best. But if there's a 0 to 100 is mild. 100 to 400 is like an intermediate. Over 400 is high. I have patients with a 5,000 calcium score. That means there's a lot of plaque everywhere. Plaque does not mean that they're going to get a heart attack. Plaque does not mean that they're going to get the symptoms. I have patients with a calcium score of 3,000. None of the plaque is more than 50% to cause any symptoms. We did the stress test, we did the catheterization on these people. So there are multiple studies show that just because there is a plaque does not mean that that's going to increase their risk to significantly, but they can develop with the time, they can get the symptoms. If the blockage becomes 70% or more, that's when people get the symptoms. The symptoms like heaviness in the chest, shortness of breath, mostly exertion related symptoms, feeling tired all the time. So in anybody who has exertion related tightness, heaviness, pressure, jaw pain, shoulder pain, shortness of breath. So those are the kind of things definitely you need to get evaluation done, so that if there is a blockage of 80, 90%, if we cannot control with the medications, that is the time to put a stent in. One thing I want to emphasize, stents do not prolong life, except in the setting of a heart attack. So there are a lot of people who had a stent. Just because you have a blockage, you do not need to have a stent. So stent is only to prevent the symptoms. If somebody has a 90% plaque, I cannot control with the medications by giving 2 or 3 medications and they're still having the chest pain every time they walk. Those are the people who will get the benefit from putting a stent in. So we can relieve the symptoms. So they did a studies with 10,000, every one of them had 70% or more blockage. 50% got the stents, 50% did not get the stents. There is no difference in mortality or the survival for people who had the stents versus who did not have the stents. So in both the groups, about 6 to 7% of the people died. But just because somebody had a stent in that 5,000 people did not die any less over the 5-year period, but people who did not have a stent die any more. So the bottom line is stents help to relieve the symptoms. If somebody comes in with a heart attack with 100% blockage, yeah, absolutely. By putting a stent in will definitely make the heart muscle not to die. So we'll make the life prolonged in that scenario. And if you have a lot of blockages, multivessel disease, all 3 arteries have 99% blockages. So that means, yeah, they will have problems in the future. So those kind of people, it may help. But in one blockage of 80%, 90%, that does not increase the risk of dying for that person. The second point I want to stress is plaque doesn't need to be 80% or 90% to cause a heart attack. You can have a 30% plaque or 20% plaque, which can rupture, can cause a blood clot, Blood clot makes it 100% within 5 minutes. So you have a plaque 20%, you can run a marathon, no problem. But 10 minutes later, if the plaque ruptured, it's like a cut. When you get a cut, what happens? Our blood clots off so that it doesn't bleed more. Same thing happens within the blood vessel where the plaque ruptures and we have a blood going through that blood vessel where it thinks there's a cut and it forms a clot. Unfortunately, the clot kind of blocks the whole artery. So the distal blood flow to that area where that artery is supplying goes down. So the muscle starts to die. That's when within 15 to 20 minutes, people get a lot of symptoms, chest pain, shortness of breath, sweaty, nausea. So if that's not going away in 15 to 20 minutes, I think you'll be better off going to the hospital and get it checked. So if it is 100% blockage, that can cause what we call arrhythmias or a ventricular fibrillation, which can cause a sudden death. So about Indians, unfortunately, if people get a heart attacks in Americans, there is a 5% chance of sudden death. In Indians, it's about 20 to 25%. So that's how we see so many of these people having a sudden death because of the plaque, which was 20%, suddenly ruptures, forms a blood clot. Unfortunately, if it happens in the main artery called LAD, which is a left anterior descending artery, that supplies a lot of heart muscle, and there is a more chance of people going into ventricular fibrillation or asystole, and they die. So CPR is that's why very important to learn the CPR so that until the EMS comes and if the person is in ventricular fibrillation, if you do the CPR and keep the brain going with the blood flow supplied by the CPR, you can save the brain while the EMS comes and gives a shock. Shock will get the person out and then they can go to the hospital and get it fixed. But if that 20 minutes, if the brain is not getting enough blood flow, even if the EMS comes and gives a shock, brain is already dead and we can't do anything about it. So I think everybody should learn at least the basics of how to do the CPR so that make the patient be alive until the EMS arrives and so that the chance of survival will be a lot better. So that's about the testing. And if you have if you're having symptoms, then we decide to do the stress test with the nuclear imaging or a stress echocardiograms or a CT angiograms. So there are a lot of other tests we can do for symptomatic patients, but symptomatic patients, I think they should go to the doctor and get the checkup done so that we can identify if there is a problem, what we can fix either with the medications or the stents or the bypasses. If there are a lot of blockages, then we need to go for a stents and the bypasses. The treatment, there are really good treatments available. Aspirin helps, cholesterol medications help, controlling the blood pressure, controlling the cholesterol, controlling the diabetes. All those are you need to take care of that so that the risk of the plaque building up again and rupture, and then the prevent the heart muscle damage. And if there is a heart muscle damage, what it causes called congestive heart failure, where the heart muscle instead of contracting normally by a thing called ejection fraction, how identify how much the heart muscle function is, normally is about 50 to 60. So when somebody gets a heart attack, it causes the damage and the ejection fraction can go down to 30%, 25%, 40%. So when the ejection fraction is less than 50%, these people can develop the heart failure where we collect fluid into the lungs and they cannot breathe and they can't lie down. They call chronic cough. It's also common in those people too because they can't lie down because of the fluid in their lungs. So those are the people. There are medicines, great medicines now, and there are defibrillators we can put, pacemakers we can put if the heart rate is slow, so to prolong their life and make the quality of life better. So those are the different kind of things we do. There are transplants available. Now there is a great artificial hearts called LVADs, left ventricular assist devices, which kind of makes the quality of life better for patients. And some people need the transplant if the heart muscle is so much damaged. So treatment point of view, there are a lot of things available. I want to into the treatment part of it, but I think that the risk factor modification and the testing to find out if there is anything, especially the two things can bother me: people with the diabetes and people with the family history. If you have a family history, somebody, an uncle, aunt, father, grandfather, anybody had a heart attack, especially at a young age, doesn't matter how good you are, how much exercise you do, doesn't matter. It's still going to may happen to 50% of the people. So you need to have it checked sooner rather than later. There was a question about why people with exercising and dying, those kind of things. So plaque rupture can happen anytime. There is no rhyme or reason why, this is the reason why. So there are some theories, people who are under stress, plaque rupture can happen more frequently. So that's why you see somebody is a bad news and they can get like hold their chest and have a heart attack. Sometimes the viral infections in a seasons where a lot of viral infections that can increase the risk of the plaque rupture. So smokers, definitely risk of a plaque rupture is way high, and smoking also makes the blood a lot thicker. So I think those are the kind of some theories about the plaque rupture, which increases the plaque rupture, but there we definitely not know that not all the factors are known why some people get the plaque rupture, some people don't get the plaque rupture. I have patients with a 4,000 calcium score, so that means a lot of plaque everywhere, but none of them ruptures. I also have patients with a calcium score of 2, had a plaque rupture, came in with a heart attack and had a stent and gone on. Some people died of the plaque rupture. So if the plaque rupture happens in a bad area of LAD, that can cause the ventricular arrhythmias and die. So that we cannot avoid it, we cannot predict it. So these are the people who died during the exercise. It so happened that the plaque rupture happened at the time. And some people go to sleep and never wake up. Plaque rupture happens in the night. So it happens when people goes into ventricular fibrillation and they die. They woke up when in the morning, the people find out, family find out that patient is dead. So that is also the arrhythmia happening because of the plaque rupture. And some people also have arrhythmias. It's not all the time heart attacks. Okay, there are other things also can cause a sudden death. Some things I think Prasad deal with all the time is the pulmonary embolism. If there's a blood clot in the legs, it goes into the lungs and it blocks the main artery and people die suddenly. And people have aortic aneurysms, they rupture and people die suddenly. And people without heart disease, they can also have arrhythmias where heart just born with a defective kind of a anomaly in their calcium, potassium, magnesium metabolism. So these people are more prone to develop these arrhythmias or sudden death. So that's a possibility too. Or the hypertrophic cardiomyopathy, which is a thick heart muscle in the septum, people have that, and those people go more into arrhythmias. Also, these people die when they're really active and playing basketball and football and exercise. So when these people, when they had a sudden death, and if they had a hypertrophic cardiomyopathy not diagnosed, and they were exercising and died, that could be sudden death because of hypertrophic cardiomyopathy. So not all sudden deaths are because of the heart disease or blockages. So there are other reasons for the sudden deaths. So we don't go by just one thing, but heart disease is the most common one. Blockages is the majority. 70 to 80% of sudden deaths are because of the heart disease. So I don't want to minimize that, but there are some people die because of other reasons too. So it's not, heart disease is not the only thing. The blockages are not the only thing which can cause a sudden death. Just want to emphasize that. So in conclusion, so identify the risk factors. So take care of yourself, take care of if you have diabetes or hypertension or cholesterol, exercise regularly, watch your diet and do at least 30 minutes of exercise every day, and go to the plant-based diet if possible, but not necessarily all the time. But I think moderation is the key. So whatever you like to eat, but eat less of it. If you can go to plant-based diet, great. But that's not not feasible for everybody, I understand. And definitely smoking is absolutely no. And there are a lot of questions about here all the time. So alcohol in moderation is okay. 3 to 5 drinks of alcohol, mostly wine. Those kind of things are good, but not too much. Not a whole bottle, but just the 4 to 5 drinks is good. Not the big bottles of the whole bottles. So that is my suggestions. I think sleep is important, like Prasad said. I think sleep is important. Exercise, diet, those are good things, and take care of your risk factors. Be proactive, not reactive. I want to emphasize that again. Thank you. Thank you. And I had one more thing. I think GATES has been doing a wonderful job with all these sessions and a lot of other activities. I commend the whole leadership team at GATES. I think every year I see they're going to the next level. When I was involved with GATES, unfortunately, I don't have that much time right now to be actively involved with the GATES, but I think you guys are doing a tremendous job. Congratulations for a wonderful job you guys are doing. Keep up the good work.
Thank you, Dr. Gangasani Garu, and we're just following your footprints and advices, and we need your support and blessings, Dr. GARIMELLA Garu and all advisor team members. We're trying to balance between the cultural and the service in back home and also in here, and we're trying to bring all our youth, especially because of our generation only basically connecting with these organizations, but the next generation also has to be involved and they have to take a leadership role.
Absolutely. Agree.
Yeah.
So as Janardhan Garu said, thank you very much, Dr. Garu. You're always a role model to not only the parents as well as kids too. We always look up to you. So we got a couple of questions when we say we have this session. So I want to read out one question. So the patient is 72-year-old female. So she's telling she has a BP and heartbeat gets fast every few weeks, and doctors suggested to do ablation. So she's asking, is it a good idea to do it, and how risky, and what are the risk factors in it?
So I think that ablation is kind of a new for my Indian patient point of view. In India, we never used to do ablation. This is a kind of a new concept in the last 15, 20 years, depending on what we are doing it for. So there are at least, there's a thing called atrial flutter for which ablation is easy. So it's on the right side. We go through the leg. It takes about 15, 20 minutes, put a little scar tissue. Ablation means there is an extra electrical circuit in our heart. By putting a catheter, we burn the extra electrical circuit so that there is no going round and round, which will make the heart to go faster. Okay, so it could be atrial flutter, it could be SVT or supraventricular tachycardia, it could be what we call a WPW syndrome, where you're born with an extra electrical circuit, or the atrial fibrillation. Those are like a more common ones where we go do the ablations. So if it's an atrial fibrillation ablation, it's a little bit more long kind of a procedure, because we have to go from the right side to the left side. There are 4 pulmonary veins in the left atrium. So joining the left atrium, that's where the atrial fibrillation comes from. So we put the hole in the septum, go from the right side into the left atrium, and then put a little scar tissue on the 4 areas of the pulmonary veins. So it's a little bit more complicated. Having said that, the risk of any of those ablations is less than 1%. So if somebody is being affected by the symptomatic, the palpitations and not feeling well, so if you cannot control with the medications, ablation is a great option. So I'll tell you, if any of those 4, I have it, I don't even think for 5 minutes to get the ablation done, because that is a cure. So by medicines, you're kind of putting a Band-Aid. By doing an ablation, you're permanently curing it. I would rather take that less than 1% risk to take care of it. Atrial fib is the only one which I would hesitate a little bit more before I go for an ablation, but flutter, atrial SVT, WPW syndrome, I don't even think for a second go for an ablation. Atrial fib, I would try even for my patients, I don't send for ablation right away. I treat with the medications. There are beta blockers, there is antiarrhythmic medications, and then the ablation. So if these don't work, that is the time to go for an ablation for AFib.
Thank you very much. I hope they're listening. And even
72-year-old is not a high risk at all. So I've seen people with 85-year-old, 90-year-old going for an ablation. For an ablation, 72-year-old is a very young.
Wow. See, 72-year-old is also young.
Very young.
So the next question is, they're asking like a 30% of a blockage can be cleared with medication in a patient who has already 1 stent.
So 30, as I said, below 70%, we don't do anything. Below 70% plaque, we just need to do the risk factor modification. So by doing everything right, by controlling the risk factors, most of the time you slow down the progression. Once you have a plaque, it's not going to go away. There are a few studies which showed about 10% of the people, plaque can get regress. So plaque regression is seen in studies in 10% of the patients, but 90% of the patients, by doing everything right, you can stay or slow down the progression. So eventually, so I'll tell you this, I have one guy, there's 60% blockage in the right side artery, 30% blockage on the left side artery. He's my patient for like literally 20 years. He was one of my first patients in 2000. So like 23 years he's been my patient. So he came in at least 10 times over the last 20 years with chest pains. So every time he come in, because he has a 60% blockage, maybe that is getting worse. So his 30% became 90%, but 60% is still 60%. Same person, same diet, same everything is same, right? Same person, one blockage, which is 60% not gotten worse in the last 20 years. And he had like a multiple 30, 40, 50% blockage has gotten worse. He has another 6 or 7 stents over the last 20 years, but his 60 is still 60. So my point is, no way you can predict whether this 30% is going to go to 90% or stay 30%. If you do everything right, your chance of progression will be slow. It's never going to be 0. So I believe in doing what is the right thing. So the way I tell my patients all the time, if you're going on 85, there's always a chance of having an accident. Somebody can come and hit us. We cannot control that. You control what you can control. Don't worry about the uncontrollables. You do the right thing, so that sometimes plaque rupture happens, plaque progression happens. But as long as you're controlling your cholesterol, you're controlling your diet, you're exercising, that's not in your hands. So you do what you can do.
Thank you. So the next question is, the patient, she's getting like skipped beats 3 every minute, like how to get rid of them.
So those are called palpitations. So most of the time, those are because of the extra beats. So heart has a pacemaker we're all born with called SA node. So that gives a beat every second. So that's normal. So suddenly there is a different area becomes more active and it starts to give a beat. Either it's coming from the upper chamber, it's called PAC or premature atrial complexes, or PVC, which is a premature ventricular complex, which is coming from the lower chamber. So you just need to identify which one is the one which is causing that palpitation. So basically, if you do a monitor or an Apple Watch or a cardiac monitor, so by wearing a monitor, we can identify what is causing our symptom. There are 20 different things can cause it, but these are the two common ones are the PACs or PVCs. So once we identify, we can control with the medications. First thing is avoid the excessive caffeine, chocolate, alcohol, stress. All of these can cause extra palpitations. So these are all events which can trigger in a person who has a tendency to have these palpitations. So you control those first, and then the beta blockers, and then like what to do with the ablation. The ablations work for that too. So, but I think that's the last resort. But I think the first thing is avoid the caffeine, chocolate, alcohol, and stress.
I know, I mean, I'm healthy, but whatever you mentioned, I have all those bad habits like coffee.
Those are not bad habits. I think do it in moderation. Do it in moderation. But somebody who has palpitations,
I know.
who just stop the caffeine, like you go for 5 cups of coffee every day, they go to 2 cups, their palpitations are gone. So it's some part of it is controlling the stimulants. So you need to avoid the stimulants in that scenario.
Sorry to interrupt you, Josna Garu and Dr. Gangasani Garu. I know Dr. GARIMELLA Garu, he's signing off. Thank you, Dr. GARIMELLA Garu. I know you are working so hard, late nights, and also I know your time is very precious at this moment. So thank you for educating us.
Yeah, thank you, Prasad.
Thank you again.
Thank you very much, Prasad Garu, for your time and effort.
Thank you, Prasad Garu.
Thank you.
Thank you.
So let's continue taking next question.
Okay.
So aortic valve trial reflects thicken at the age of 73 male active person with a diabetic. How to prevent to happen this, and what are the medications and diet restrictions, and can they?
Yeah, it's a good question. So I think aortic valve sclerosis or thickening is an age-related phenomenon. If you don't want aortic valve to thicken, don't get old. So it's as simple as that. So as we get older, our valves get, we don't look the same like what we are looking when you're 20 versus 25 versus now. So I think the body changes outside, body changes inside. So in the heart, there are 4 valves. The aortic valve is the most important valve. Each time the heart pumps, blood goes through the aortic valve, opens, blood goes out, and the aortic valve closes, so that the blood doesn't come back into the heart. So that is the purpose of the aortic valve. So because it's opening, closing every second, right? So everybody gets rest. Every part of our body gets rest. Brain gets rest when you're sleeping. Heart never gets rest. So it's always working. So because it's working so much, so you're going to have some degenerative changes. Let me put it this way. So you have a door opening and closing all the time. So after a while, you can see the little gap on the top, little gap on the bottom. So those are the kind of age-related kind of changes happens in the valve because of that wear and tear of the usage of anything. So having a little bit of a thickening is not a problem. So as we get older, somewhere around 80, so people develop more thicker calcification in the valve that makes the valve not to open like what it used to open. So normally aortic valve area is about 3 to 3.5 square centimeters area when it opens. So, but once it gets to under 1 square centimeter, that's when people need to have something done called aortic valve replacement. Before, we used to do the aortic valve replacement by cracking open the chest like open heart surgery. But now we have what we call a TAVR, which is we can go through the leg and put the valve inside the old valve so they can go home next day. So it's like almost like putting a stent. So a lot simpler procedure. So it's an age-related phenomenon. There's nothing to prevent that to happen. So there's a few studies showing that if your cholesterol is high, that calcifications can happen more frequently. So basically by controlling the cholesterol to some extent, it may decrease the progression, but it's just an age-related thing. There's nothing you can do about it.
So can they do like small exercise, those things? Like
yeah, exercises are good. Yeah, as long as the valve area is less than more than 1, it's okay to exercise normal. Anything with exercise should be symptom limited. If you're getting the symptoms when you're exercising, stop and reassess. Hey, why am I getting this symptom? And then if one day it happens, 10 days it doesn't happen, I won't worry about it. But every time I'm exercising, I'm getting this symptom. That is the problem. That is the time to go get it checked to find out if there is something correctable cause, so that we can correct the problem, so that you can go back to the exercise. Exercise is important. Exercise is very useful. So Timing is more important than the intensity. People don't need to run fast. Go slow, go long. I would rather go for a 30 minutes, 40 minutes of walk at 3 miles an hour rather than going 5 miles an hour for 10 minutes and stop it. So you get more benefit going longer, slower, rather than faster and shorter.
Well said. That's really helpful. So the next question is, one of the listener is asking, like, after a bypass surgery, like 5 years later, if somebody exhausts injection fraction 40%, like, what do you suspect? Like, what are your, what do you think?
Yeah, so that's what I was telling about. The ejection fraction is how much heart pumps each beat. So normally, if 100 ml of blood comes into our heart doesn't squeeze completely. So basically, it squeezes in such a way that only 60 ml goes out, 40 ml still stays in the heart. At the end of the systole, where the heart contracts, you still have about 35 to 40 cc still in your system. So that, but when you exercise, it goes faster so that you can get more. So it may pump out 80 ml, 90 ml out of 100 ml when you're exercising, because you need more blood flow to your muscles because you're exercising. But for regular daily activities, when you're not doing anything much, or even for regular walking and stuff, normally your heart pumps out only 60% of what is in the heart at the time. So when they say 40%, that means that there's a damage to the heart muscle, which is making that part of the heart muscle not contract. So instead of pumping out 60 ml out, that heart is only pumping out 40 ml.
Got it.
70 is normal range for us for ejection fraction. So 40% means there is some damage to the heart muscle. Most likely, the person had a heart attack before or heart attack in between after the bypass. Also, sometimes the silent heart attacks happen, especially people if they have diabetes or a long-standing hypertension, they may not know. Especially if they had a 5 years after the bypass, if the ejection fraction was over 50 before, now it's 40, I think they definitely need to have it checked for any new blockages. So bypasses don't last forever. Bypasses, normally guidelines are after 5 years, you need to have a stress testing done. Also after that, every 1 to 2 years, you need to do a stress testing so that you know. If they're symptomatic, if they're getting more shortness of breath, more chest pain, sometimes we may go for a catheterization rather than doing a stress test in that scenario, because the ejection fraction dropped. If they're having symptoms, I just want to make sure that there's no blockage causing the heart muscle not to get the contraction the way it's supposed to be. And I have patients whose blockage making them to get weaker. Once we fix the blockage, heart muscle comes back to 50%, 55%. And there are also medicines, like 3 different medicines we use to get the heart muscle stronger, and that person should be on those medications to get the heart muscle stronger, or at least not to get any more weaker than what it is already.
Nice. Thank you. And the next question we'll take from Ramesh Garu. He's asking, like, how to avoid blood clots, rupture, or there any blood purifiers? Does blood thinners help blood clots? And can we use it like for longer period? Will that affect in a good way or a bad way?
Okay, so the blood thinners is a controversial topic. So the reason is the blood thinners definitely make your blood thinner, definitely decrease your risk of a blood clot formation. But the blood thinners itself cause some problems. By taking the blood thinner, you can have a bleeding problem. You can have a bleeding into your stomach, bleeding into your urine, bleeding into your brain. So those can happen too. So there is a risk versus the benefit. The controversy is more because of the risk versus the benefit. So if you put everybody, we give a blood thinner, definitely their blood becomes thinner, but you will be causing some strokes because of the bleeding into the brain. GI bleeds because they're bleeding into the stomach, because the blood thinners also makes your blood, the ulcers to bleed and then cause the ulcerations in some cases. So that's where the risk is. Yeah, you take the blood thinner, but there is also risk of bleeding. So we try to give to the patients the blood thinners in only people where we think risk versus benefit outweighs the.
Okay.
Hello.
Yeah, Josnagar, yeah.
Yes. Dr. Garu, are you there?
Medication, your risk is only 1%, but the risk of a blood clot formation, but the risk of blood clot formation is 1%, I won't give it. So that's the way you need to look at. If somebody has a previous blood clots, or if somebody had a heart attack, definitely they need to be on a blood thinner because their risk of another blood clot formation and causing a heart attack is higher. So those people should be on. If somebody is smoking, and if I'm going to India for sitting down for a long period of time, I may take just aspirin more so at the time so that I don't have a blood clot, because there are some scenarios where you can form more blood clots than other scenarios. So I think if you are traveling a lot and you just get up and walk around every 20 minutes, 30 minutes so that you won't form a blood clot in the legs. And if you already have a blood clot in the legs, definitely those people need to be on a blood thinner. So there are two different agents for a blood thinners. One are called antiplatelet agents, and another group called anticoagulants. Like anticoagulants are like Coumadin, Xarelto, Eliquis. Those are the blood thinners for people who had blood clots in the lungs or in the legs. But the antiplatelet agents are what we use in the cardiology to prevent the heart attacks, like aspirin, Plavix, like Brilinta, Efient. So those are the antiplatelet agents. They work on the platelets to prevent the clogging of the arteries. Whereas the blood clots are in the veins, the DVTs are deep venous thrombosis. So those are two different kind of things. The simple answer is not blood thinner is not for everybody. So talk to your doctor. If your risk is higher, definitely they will help. If the calcium score is elevated, in a heart case, if somebody did a calcium score, their calcium score is 100, definitely I put him on aspirin at least, because those people already shown that they can form the plaque. So by taking care of the aspirin, so that will decrease the risk of heart attack by about 20 to 25%.
Can I add one quick question to that, what you have said? Like when you said this blood thinners, I heard like, the people who this thyroid thing, they also take the blood thinners. Are they different from this?
Thyroid thing, they don't take the blood thinners. The thyroid, they never take the blood thinner. Only time thyroid people, they can go into atrial fibrillation. That can cause the heart to get the blood clots, and those times we use the blood thinners. Not everybody with a thyroid do not need to take the blood thinners.
So the thyroid patients, what they're taking is not the blood thinners.
Oh, no, not at all. That's the Synthroid. Synthroid is a thyroid supplementation, because your thyroid is producing less thyroid. So basically you're supplementing extra so that you get the thyroid into your body even. That's not a blood thinner.
Oh, good to know, because my mom is taking.
No, that's not a blood thinner.
Yeah, just
That's
want to.
definitely not a blood thinner.
So the next question is left atrial enlargement due to depression dangerous?
So left atrial enlargement is very common. It's age-related. So people with a hypertension have a left atrial enlargement. There are 4 chambers in the heart, 2 atria, right atrium, left atrium, ventricles, 2 right ventricle and left ventricle. Left atrial enlargement is very common. If somebody read it on the echocardiogram, left atrial enlargement, not a problem. So if somebody is a hypertension, always, once I have this patient with a 50 or above, so heart becomes a little stiff. So stiff heart makes the heart to get a little hard to contract and relax. So the relaxation becomes a problem. Upper chamber gets a little bit bigger to push the blood into the ventricle. So it's very common, left atrial enlargement, not a big deal. If it really gets bigger, people, as you get older, they can get atrial fibrillation, which is a little bit more risk of having atrial fibrillation if the left atrium is enlarged over the time as you get older.
But the listener was telling, like, the patient is 21 years old and he's young.
I think left atrial enlargement in a 21-year-old is very uncommon. So if there is a left atrial enlargement, they need to look for other causes. If they have a mitral stenosis, or there should be another reason to get a left atrial enlargement. It's not common to have either the diagnosis is wrong, or if there is really left atrial enlargement. In India, we used to see a lot of rheumatic heart disease. So people used to have a valve disease. So those people can have a left atrial enlargement. It's very, very, very uncommon to have a 21-year-old with a left atrial enlargement just like that. So they should look for a reason.
So they want to know, like, if the patient has like this depression and anxiety thing, will
that should not cause the left atrial enlargement. There's nothing to do with the structure of the heart and the depression. No, they can get palpitations because of the anxiety and stuff, but that structurally, it does not change the left atrium having a depression or anxiety directly.
I hope that helped. Thank you. So the regular question, but which is very important, what are the
sorry to interrupt. I know we passed our time. I know we in 1 hour window. Yeah. But just please catch up. I know Dr. Garu time also very precious. And
I have a 2 o'clock in the meeting in downtown. So I think another 5 minutes at 1:30 I had to leave. So
yeah, and also I will post all those questions. If anybody's have any questions, I will share with Dr. Garu, and then I will share with you all. But just please connect with the GATES, and also we have a YouTube channel. Please subscribe, and also we have a Facebook page too. So if you all keep in touch with us, then we can bring more programs. And especially thank you, Dr. Gangasani Garu.
Yeah, you're welcome.
Thank you, Dr. Garu. Thank you for your time. And definitely we have more questions. I'll make sure
that I can take a couple more questions. I think.
And also one of the patient, he want to share something about you was helped him, and he would like to share.
Yeah.
Okay, Dr. Garu.
So,
Yeah, I think go ahead.
Jonathan?
Yeah, go ahead, Sudhakar.
Hey, hi. Hi. Hello, doctor. This is Sudhakar. Few months back, I don't know, maybe around 6 or 8 months back, my father was like, no, he got attacked and then like he was in critical position. So he was admitted in Orchard Hospital. And you only helped us like, no, I think like talking to doctor, I forgot the doctor's name, the Orchard Hospital.
Oh, okay.
I hope like, so with your reference only, like, no, we got lots of help. So thank you so much because of
Thank
your,
you.
yeah, because of your help, like, no, my dad, like, no, he's doing good now. So thank you so much.
Good.
Like, no, it's really a timely help. And thank you, and thanks, Jonathan, too, as well.
Yeah, no problem. I'm glad he's doing better. I'm glad we could help.
Sure, doctor. Thank you.
The question about the vitamins. So I think usually our diet has a good vitamins most of the time. But if you're really not eating that healthy kind of a thing, or if you think, sometimes vitamin B12, those kind of things can be low. So one multivitamin, it doesn't hurt. I don't take regularly multivitamin. I may take once, or actually, during my talk, my wife gave me a couple of vitamins to eat. So, so we have a vitamin gummies at home. So every once in a while, once a week or so, I'll take one or two. So, but I don't take it regularly. But one regular multivitamin a day doesn't hurt. And so usually the advantage of the vitamins is B complex vitamins. If you have enough in your body, it doesn't get absorbed. So if you have low in B6, but B1 is okay. When you take a multivitamin with all B complex things, so only whatever is deficient in your body, your intestines absorb, others you don't. So that way, I think you don't need to worry about getting toxicosis from that extra vitamins from a B complex. But the fat soluble vitamins called like A or D or the K. So those, if you take too much of those, sometimes they can accumulate more, so which can be more dangerous. But B complex is not a problem. So I know there was a question about vitamin K in the beginning. So vitamin K, that there are some studies there, but there's nothing foolproof or nothing concrete to say that is good or bad. So vitamin K is the only thing which we worry about is when somebody's taking the blood thinners called Coumadin. So that's how I think the vitamin K works with the blood thinners. So I think if somebody's taking the Coumadin, you need to be more careful with the vitamin K kind of taking on regular basis.
Thank you. I want to say that, because of this social media or whatever, this awareness, one way it is good, one way which made, especially I'm talking about myself, make more panic thing. Like, we get these messages like the people are like, getting heart attacks with early age. I don't know, people playing cricket and suddenly he passed out, and like, tennis, suddenly they're very athletic and healthy and everything. But when I heard your session today, I felt like, prevention should be done before than to be feel sorry. And the way you said, like, 72-year-old is also too young and can be treated. Now it gave me like so much positive, especially, we need to take care of ourselves first, make sure we go and check our body and prevent before it gets worse. Thank you very much for your time and guidance and always supporting GATES.
Thank you, Jasnagar. Thank you, Janardhan, for the opportunity. And that last part, I think there was a question about the plaque progress even with the regular cholesterol. Yes. So cholesterol can be normal because it's not the only thing which causes the plaque progression. As I said, there are a lot of risk factors. Cholesterol is one of them. And we still don't know all the risk factors. So I have patients with the 30-year-olds with no risk factors, nothing. Cholesterol is normal, no hypertension, no diabetes. They still had a heart attack. So there is nothing 100%, oh, my cholesterol is normal, I don't get a blockages. That's not correct. So I think anybody can get it. When I was in India, 22-year-old had a heart attack. I think in India right now, between 20 and 30, every week they see 1 or 2 patients with a heart attack. Unfortunately, no offense with the IT people, but there is like in India, they're working harder, they're making more money, but they're eating a lot of wrong foods and no time for exercise. So I think all that is making the heart attacks to happen a lot younger age. So I think you guys, I think everybody need to take care of their thing. I think their body. So I think there's no 20-year-old getting a chest pain, go get it checked. No, there's nothing. Oh, I'm only 20. My cholesterol is normal. Doesn't matter. Your cholesterol normal. You don't know diabetes, no hypertension. Still can get heart attack. Still plaque rupture can happen. Still people can die suddenly. So I think there's no foolproof way of telling for anybody. Even if somebody calls me, I said, I got to go to the hospital, get an EKG done, get some testing done, so that you can be sure of whether it's going with a heart or something else. So, but I think ultimately be proactive, go to the doctor, get it checked, and take care of yourself and your body.
Yeah. Thank you so much, Dr. Gangasani Garu and Dr. GARIMELLA Garu, and our pranams to you. I know you were, as I said, we both are, very busy, and in your busiest time, you spend a couple of hours with us. But behind any program, GATES spend, a lot of time behind the scenes, and especially our team. We have Naveen is here, and also Ramana Gandra is here, and also Arun Kavati. He's the one actually monitoring the YouTube now. And also Josna Palakurti and Raghuir Reddy, and also all the team members. They're working diligently, working so hard, the back the scenes. So, but thank you so much for everyone's support. And as I said in the chart, so please try to connect with the GATES, and we can bring more programs. We can build a better society.
Thank you, Jonathan. Good luck. Best wishes for your presidency. I think you started very good. I think keep doing the good job. I think every year, as I said, it is getting better and better. So looking forward to great activities from you and your team. Thank you.
Sure. Thank you, Dr. Garu. And if any team want to say something to Dr. Gangasani Garu, all the team members, I know if you want to sign up, Dr. Garu, that's okay. Or if you want to hear from our team members, please go ahead and Naveen is a secretary, and Ramana Gandra is a
Srini Garu, I think thank you is not enough to say. I don't know how much big words to use, but you are helping not only on the sessions. From last 3 years, myself and some other helpline team members reached out to you several times from the helpline point of view. Thank you for all the support and guidance for various community needs, as well as the continuous support to GATES. Thank you.
Also, we have a helpline too. Helpline number we have. I think Naveen, you can also, if you have, you can share.
Yeah, we will update in the Facebook. So if anybody would like to take it, they can go through Facebook.
Yeah, thank you, Naveen. I think it's not possible every time, but whatever we could, we'll be happy to help. I think everybody gets busier with it, a lot of other activities too. So sometimes it's not feasible on the WhatsApp messages and stuff. So we'll do whatever we can. I mean, it just makes us happy to help the community. No problem.
Yeah, understood. And I know whenever you get time and you responded back to us, but
quick, within seconds, you send a message to us, no matter what, is 5 a.m., 6 a.m. and really we applaud. I know, how do you find the time, Dr. Garu?
The problem for me is if I don't answer now, it goes into the back. I think then about it. So I want to do it then. So if I didn't answer, that means that if I'm doing a procedure, when I come, like if I do a pacemaker come out, like a 20 messages, okay, I'll take care of this. If I don't get it, just send me again, because if I didn't answer, that means that it's not in my, I think the radar, again, it's gone out of my radar. So I want to take care of it right then and there. Otherwise, it becomes a little bit difficult to go back and look at it.
Thank you.
Thank you.
Ramana Gandra?
No, whatever I had to say, I mean, we pretty much covered it. And all I can say is thank you, Dr. Garu, for your time, precious advice, and everything that you do for GATES. Thank you.
Thank you. Appreciate it.
Thank you. Josna, if you are there, then you can also say something, but otherwise we will sign up. But if anybody have any questions from the team, Doctor, that up to you, or if anybody have, then, we can interact. Otherwise,
I'm going to leave, Janardhan. I think at 2 o'clock, I need to go to downtown.
Okay.
We're doing that blanket program. So I think there's...
Sure. Josna, do you want to say anything at the end?
I already mentioned, I'm always like, thank you.
Thank you.
Thank you. Take care. Bye-bye.
Otherwise, we're going to be sign out. If anybody have any questions, you guys can talk to us, or talk to our team. Otherwise, we will exit. Yeah. So I think, okay. Thank you all. Thank you all for joining with us. Okay.